begin. So welcome and thank you all for coming. So this is going to be a different kind of meeting that we're having today. Instead of presenting lots and lots of topics, we were asked by President Stanley to have what's known as talking points, and directors at the hospital and some other managers, perhaps in nurse managers and others, are also having these meetings. And I understand that these talking points are occurring not only here at Stony Brook Medicine, but also throughout the university on both campuses. So normally we have only, and we've been having 10, for the most part, departmental meetings monthly, 10 monthly meetings. Of the 12 months, we have 10 department meetings. And we've been doing them, and I think they've been going over very well by having simulcast in from the Health Science Center and to Ronkonkoma, as well as having videotapes and staff attending virtually, and then being able to be interactive with their supervisors and our email and so forth with their questions, so that they can continue to be interactive. But we thought that because this is something that we've been asked to really go out there and discuss, that we would reach out, and we repeated the meeting. So this is our 4th meeting of such kind this week. So we had 3 others, and they were well received by those who attended. So what we thought we'd do, based on that, they seem to be going well, is that a couple of the meetings that we have, the monthly department meetings that we have throughout the year, maybe a few of them, we'll try to do this way, with a little more high touch and have more of those in-person meetings. But for the most part, we also plan to continue this kind of meeting that we're having today. And even when we have the others, we always would want to have this kind of meeting so that we do have it taped, so those staff who can't make it, who are away on vacation and so forth, day off, shift unavailability, etc., can attend virtually. So that's what we wanted to start. Now, normally we have some notes, and I don't read a lot from a script, but because the points that were shared with us to present are very specific, you're going to find me doing a little more reading, and that way I can make sure that I get everything covered exactly. So bear with me with that. But I think that way we'll cover everything. So you may recall that a few months ago we had a meeting such as this, whereby a PowerPoint was presented, and in that PowerPoint it was suggested that 60 representatives from Stony Brook Medicine attended a meeting to discuss a number of hospital-wide or health system-wide issues that had to do with future planning, that had to do with morale, that had to do with communications, that had to do with respect, that had to do with program prioritization and those kinds of matters. This initiative is coming forth from that. And at that time, we were informed that there would be additional follow-up, and we'd hear more about it. So this is the first of that. More is coming next month in October. So I'm going to start reading. Now, some of you may remember that recently President Stanley sent an email. You may have received that. If you do, you're welcome to raise your hand to see if you did. I'd be curious to know. Okay, you remember it. Excellent. A few people got it. Reinforcing Stony Brook's commitment to diversity, equity, inclusion, that encompasses a broad definition of diversity with a focus on race, ethnicity, age, gender, religion, ability, also known as disability, veteran status, socioeconomic level, and sexual orientation. So we want to take this opportunity to reiterate this commitment, and that's why we were asked to have these talking points of all of our valued employees for their help and support. And what I like seeing here is that it notes and recognizes that we as employees are valued. The work we add is value added, and that's important to remember throughout these conversations. So I'm going to proceed. As a Tier 1 hospital, our service extends to most of Suffolk County. Patients and their families who utilize our facilities are from all walks of life and represent many dimensions of diversity. Being culturally competent and respectful are crucial components in providing high-quality medical care. Communication and language are important, so we need to be mindful of the words we use and mindful of the tone in which we deliver them. So that's 2 points: what we say and how we say it. So that's a takeaway. In addition to providing superior medical care and services, we need to strive to be respectful of others at all times. With that in mind, President Stanley writes, I am asking everyone to be more conscientious of how we, and that's all of us, speak with patients, families, and our fellow coworkers. So that's the other dimension that we also often talk about, patients and families and our customers and our stakeholders. But coworkers is important to keep that in mind. So I'm going to continue reading. Accordingly, please refrain from using any derogatory or disrespectful language. Here are some important points to remember. And this is very specific, and we're reading them through. Adults should not be referred to as boy or girl. We should also aim always to identify individuals by their names whenever possible, not using pronouns, particularly in the third person. If someone's there, two people are talking and the third person is there and referring to the third person, certainly including them in the conversation. That's an example. It says here, if we do not know the name and need to describe the person, let's use appropriate, formal, and polite terms. Not slurs, informal terms, nicknames. If we do not know the name and need to describe the person, be careful and mindful of how we describe them. Some people may not like to be referred to as that ginger guy, that blonde lady, that maybe the person standing next to the light lamppost, the person standing by the chair, the person in the blue coat, the person carrying the umbrella, as opposed to a physical characteristic, if and when possible. In times of safety, we say whatever we have to, but in general, these are the guidelines we're given. No matter how busy or how stressful our days are, the use of profanity is never acceptable, nor will it be tolerated. So in addition to ensuring that each of us adhere to these expectations, we have a responsibility to bring issues to our supervisor and the manager or the director or HR or however it's appropriate if these things occur. Now, we all know that in patient access throughout the whole hospital and maybe the university, these kinds of things may be prevalent. And we all hear of a situation where this employee is having a bickering or something else with another. We're asked not to talk about that with each other. Bring it to a supervisor. We handle the safety, but let's not talk about it. I think that's a takeaway to this kind of thing. So that's something that we're going to share. Try to maintain professionalism at all times with this, and let's not make this the focus of our attention. Let's hold ourselves and each other accountable to the highest standards of professionalism so that our patients, visitors, and coworkers have a pleasant and respectful experience. This reminds me of the leadership mission that we often read at our meetings, and we reinforce that. And I know that it's enthusiastically accepted by many of our staff, and we're very proud of it. So we reinforce that here, and Dr. Stanley has reinforced it in his message. Please be aware that we will be expanding our cultural competency education offerings in the weeks ahead to further support our employees to strengthen our commitment to high-quality patient care. Now, in October, there is an event on cultural competency at the arena across campus. I believe it's called the Island Federal Arena. I have been invited. We have invited our senior managers, and if any of our staff are able to attend, and the supervisors will be able to determine if scheduling permits that session. Certainly they are invited. If any staff are off or work different shifts, they're automatically able to come. And certainly these will be repeated, and this will be the first of others. The goal is that everyone at Stony Brook Medicine, but they want to start from the top. And I think the reason is that we really need to lead by example from every level, across, around, and through. It begins with me. And personally, it begins with me. And for each of us, it should begin with me. So Dr. Stanley ends this email, and then we'll go to his talking points, by thanking us for our help and support and dedication to Stony Brook University Hospital. Now, what are we doing, before I get to some of the talking points that are related, to relate to this? And some of the initiatives we have is we have a field currently in PM office, and you may know that, called Nickname. So what we're going to do is we're renaming that. I believe we have a ticket in place to Preferred Name. Patients should be referred to by their preferred name so that the clinician can see that, and we want to put that on the banner bar. So that, well, here's an example. We have a 4-year-old child. He's a pediatric patient. His name is Reginald Jonathan Alexander Harrington IV. He's 4 years old. Now, that's his name. Well, we don't expect the clinician to call him that. His parent will say, we'll ask, how would you like him to be addressed? And the parent will say, RJ. So we can use that field for RJ, so the clinician will see that and refer to this pediatric child as RJ. And, you know, it's obvious reasons that he's going to, that's how he's known at home, and that's how he is going to be responsive, right? Similarly, we'll use a public figure who has been in the news based on gender transitioning. We had a celebrity known as Bruce Jenner. And let's say someone such as he was coming into the hospital, and at that point, the ID still had the original name. But the preferred name, as shared with the patient, because we're looking to have some scripting, and you see here, how would you like to be addressed? We're going to ask that, and there are several different scripts being determined by various committees who are specifically looking at this from the point of sexual orientation and diversity. And we'll get you the specific scripting for this. But then in the preferred name, we'd be able to put the preferred name. So we're also going to look at pronouns, how people want to choose what pronoun is appropriate for them. Now, this is very specific to those patients who have had elective sexual reassignment. Another point we've made at some of the meetings is when we'll talk about this further, but since we're talking about it, is that when we talk about the transition, there's no percentage involved. That's determined by the patient. Whether the transition is 0.1% or 99% or 100%, it should be non-relevant to us, and it's determined by the patient regardless of the clinical aspects related to that. The physicians need to know. Now, you do know that we have a field called administrative sex, and we have a field called birth sex. It's really important that we pay attention to both of them and that they're aligned. I know that IT is working with us to make sure that they are mapping appropriately. And we have some issues we have to work out because we have downstream systems that may not have two fields. We have IDX, which kind of upstreams to us sometimes, and we're exploring how that affects it. So they may not all be correct because of those interface issues. So we have to look at that, and we are. And I share that with you. So please be patient while we're working on these. And so there's multifacets. Some of it's technological, a lot of it's cultural. But the message we're sending to you, we'll talk about the specifics of the workflow. But right now, this message is more about our attitude and respect and how we're culturally aware of these kinds of issues and treat everyone with respect based on that. So I'm going to go through some of the talking points that we may or may not have, covered. When referring to an employee or another individual, use the person's name whenever possible to identify him or her. If you or the person to whom you're speaking does not know the name of the person to whom you are referring, use obvious, non-offensive factors to identify the person. We're going to try to avoid physical characteristics if possible and use more referential kinds of terms if and when possible. Always aim to use first-person terminology to describe someone. And here we have the example you see here. I am not wheelchair-bound. I am a person who uses the wheelchair. We want to be person-specific. It's not someone, another example, who is autistic. It's someone who is on the autism spectrum or has autism. It's not that they are autistic. They may have autism. This person is not wheelchair bound. They're a person who is in a wheelchair. So these are the kinds of things. Now, it takes some language shift, and some folks do this automatically. But sometimes we have to stop and think. So we understand that this is going to be a process. I don't think we're going to listen to this today and wake up tomorrow and then suddenly change the way we speak, because we speak, we're busy, we're doing work, we're focused on other things. And if we've said something one way for many, many years, a person's wheelchair bound, or the person's in a wheelchair, they use a wheelchair. So we have to learn some of these terms, and there are many of them. There are many of them. We continue. Put aside preconceptions. Do not presume that everyone identifies the same way. Understand that each individual may have their own ideas and feelings about personal preferences when they identify themselves. Since tone of voice plays a significant role in how communication is perceived, we must ensure that tone conveys respect, professionalism, particularly when describing someone's appearance for the purpose of identification. Understand and respect that English is not everyone's first language. We must be mindful, especially we, of this. We document 2 languages for patients. We document spoken language. We document written language. When we look at the RegQA system, I clearly see that only a very small number of registrations have both filled out. Most people are putting in 1. We really need to think about this. I gave some examples in our meetings this week. And picture that we're on vacation at a country where we do not speak the language at full level, but enough to speak at maybe a 2nd grade level, a 3rd grade level, how to order at a restaurant, where is the restroom, where do I take the train or the bus, and, I'd like to order this, but maybe don't have the same full command of the language as we do in our native language, right? So I might be able to speak in another language at a 3rd grade level, but I really can't explain nuance and deep concepts in that language. And many people are like that. So we meet people at registration, and they appear to speak English, and sometimes our staff asks them, "What are you comfortable speaking English?" Sometimes they ask, "What is your language preference?" The latter is the appropriate way, right? So we document that. What language would you like to read in? Why do we ask this? What do you prefer? Now, why are we asking this? This is going to go on the clinical record as to preferred language and as to written language. Whatever we have for written language, if the person has to sign surgical consents, for example, they cannot read these perhaps in English, even though they might speak in English. Likewise, maybe they're very comfortable saying, well, my spouse's name is such and such, and my address is this. We're asking them basic demographic questions. They hand us an insurance card. We ask a question. It's simple enough about their insurance. They understand it. They respond in English. But if they were having a conversation with a neurosurgeon or speaking to a doctor about their loved one and had to make decisions as to whether to do surgery or not, it really needs to be known that this person would be much better set and have the advantage and the dignity and the ability to communicate in their own language. The day before, we had one of the meetings. I'm sure she would not mind my sharing this. But Donna Konomos was very kind to share a personal experience like this. Also yesterday, we had someone from Barbara's team experience a similar situation. I'll share Donna's. They're very similar stories. One is whereby Donna was in Greece a number of years ago and was in the hospital, she said, for 12 days. And at that time, she said they had no one to speak to her in English. They did not provide her with translators. There were some complications with the reason she was there, and she had to sign documents. They were all in Greek. And she and her husband was able to understand them in Greek, but because they were complicated terms, maybe he wasn't able to translate them in English, just as she was not able to understand them in Greek in her circumstance. And she explained how frightened and how concerned she was because of this. We certainly do not want our patients or anyone to experience this kind of, have this kind of experience. So let's keep that in mind and why it's important to make sure we have both languages. Also, for safety purposes, we have mother's maiden name, and then we have patient's maiden name. They're separate fields. We do need both. One of them has to do with the patient's identification. Everyone here who may have a natural mother or an adopted mother may have a maiden name. And some people who are adopted may not know or are uncomfortable, and we understand that, and we'll note that in comments. But for the most part, people know what their mother's maiden name is. We use this for identification purposes. We had a Sentinel event a number of years ago here at the hospital, which was involved a patient with the same first name and the same last name and the same birth date, both living in Suffolk County within a zip code, one zip code away from each other, who both had the same diagnosis. And there was an issue with that. Had we, at that time, had a field as mother's maiden name for an identifier, and you know now that in search, we do have that field for this reason. This was one of the remedies. And we've added this as one of the final steps in our standard patient search. Good news. We do have a brand new patient search being rolled out momentarily. The next issue of the Patient Access News will have the first of 3 tools rolled out, and it's the easy, quick glance reference guide as to the steps for standard patient search. And we plan to roll this out ideally across all Stony Brook medicine so that not only we who search patients, but all who search patients can find this. So again, this will bring us back to patient safety, but it's all related because we're respecting the patients by taking these extra steps to make sure that they're safe and that they're taken care of holistically, both how they feel and how they're treated and what infrastructure we're providing to ensure their safety. Let's continue down this list. I'm going to read this again. It goes back to tone. Since tone of voice plays such a significant role in how our communication is perceived, ensure that our tones convey respect and professionalism, particularly when describing someone's appearance. I apologize, I did read that one. The next one was about language. While we understand that our department is often busy and that the nature of the important work we do is stressful, and we work really hard. We work really hard, and we should be proud of that, and we do a good job. But it's never acceptable to use profanity. Even if profanity isn't directed at others, it's unacceptable. Now, I'll use me for an example. I'm more likely to have something come out of my mouth if I hurt myself and hit my foot. So I have to be very mindful in this case to, if I hit my foot hard and it really hurts and it's a shock, that I don't say it or anything or whatever. Maybe I'll just, squeak, ouch. But that's what we need to be mindful. And we all know what that is for us. We're all different. We all do different things. And it's natural. We're people. We're human. It's okay. And again, this is a process. There's no expectation that tomorrow we're going to wake up and have all these new sets of behavior. It's going to be a process. And we're going to have some tools and some support to do this. They're having these sessions, and we have some time. And we think this is something that's going to make a big positive impact for Stony Brook Medicine. And you know what? A lot of the work we do and a lot of the stress we have has to do with some of these kinds of things as opposed to the work. So if we're mindful of these things and we feel welcome and supported and respectful by the people who are around us, who work with us, I think that will bring our stress levels down, not to be concerned about that we don't have whispering, oh, did you see what this one said or that one? No. Take it home with you. Don't have it at the workplace. That could keep our stress levels down. Our days will go better. We enjoy a casual explanation about something of interest, and we do our work and we focus, and we support our jobs and the organization that way. Okay, and it's reiterated here. I think we touched upon it before, and it's kind of a summary. We were asked to go through all the points. In addition to ensuring that each of us adheres to these expectations, all of us have a responsibility to bring issues to our supervisor, our department manager, or even HR, or wherever appropriate. Again, we don't want to talk to each other about it. We just report it. Now, if there's safety involved, or your own safety or concern, do what you have to do. Safety first, always. But for the most part, that should not be the case. These responsibilities are key to ensuring a positive and collegial experience for our patients and a respectful work environment for all of our valued employees. Let's hold ourselves accountable to the highest standards of professionalism so that we all have a pleasant and respectful experience. So I want to thank you all for taking time to listen to this. You're all invited to the next session, which is called Understanding Cultural Diversity in Healthcare. And we look forward to that. We look forward to continuing conversations. These were meant as talking points. So this is what we should be talking about with each other, with me, with your supervisors, with your managers, with your peers, your colleagues. And this is a good thing to talk about. This is a conversation, and we want to have these conversations. One of the before I close, at one of the meetings, when we brought this up, there may have been a few staff who may have giggled when we used a reference that when we were talking about the preferential name of changing it, because we at that meeting, one of the persons at the meeting, because we were sitting around a table, was comfortable enough, and it was perfectly fine to say the name. I believe it was Caitlin. And there was some chuckles and smirks, and we stopped, and I said, the whole point is that we have a lot of learning to do. Maybe we're uncomfortable with it. Maybe it's different for us. Maybe we have certain understandings of things like that. But there's no reason for that kind of response. And those are the kinds of responses when patients and others, or staff and anyone, any stakeholder, not only patients, are uncomfortable. So I think the last takeaway, and this was an example I gave, we used to talk about on-stage and off-stage behavior, and that was the Disney concept, and we used to teach that well. When you're in front of patients, we have on-stage behavior, and when we're with each other, we kind of think that we're behind the scenes. And I think we've come to the realization and understanding that there is no off-stage. There is no off-stage. That's not true. So when we're with our coworkers or colleagues, that whole sense of professionalism, it's not like we're home and we put on our jogging suit and relax. We're still at work. Even though we're not necessarily in front of the patient or the physician or the patient's family, we're with each other. And I think if we treat each other with the same dignity and care that we already give to our patients, and when we speak to physicians and nurses and clinicians, it's always great, but also each other, as if they are the same. And maybe in our homes we need to do that with our own people and friends with whom we're close with. So that's just the last takeaway that we're going to bring here. And from here, I just invite everyone to start this conversation, because this is a dialogue, this is a conversation, this is a process. There's no expectation that this is a one-time edict that goes out and everybody's just going to adhere to it as if we reprogrammed a computer to work differently. We're people. We're going to learn the way we do. We've been on this earth for a lot longer time than it took to have this session or the session we're going to attend in October. So it's going to take a while. But I think that we can do it. We do some great things. We have a great team. We generally do very, very well. We remember these little exceptions here and there, and they become the story, kind of like the news. There's a plane crash, and suddenly everybody's worried about plane crashes. Yeah, but there were 7,000 planes that launched from that little region, and there was one crash. Now, one is too many, but nevertheless, let's put it in perspective. So once again, thank you all, and have a good afternoon. We'll see you at the next meeting. Thank you. Thank you all for coming. Thank you.